So today then we're going to talk about the locomotor system, and we're going to talk about the symptoms involved in diseases in the locomotor system, and we're going to talk about the principles of examination, and we're going to demonstrate the examination of the locomotor system on a normal, what we call a normal person, or in this case one of your classmates, a final year medical student. So to start with then, the symptoms in the locomotor system. Remember when we talked about the other systems, we gave you very, very cryptic, short symptoms that you have to ask. Remember, in the respiratory system it was shortness of breath, it was cough and chest pain and nothing else. That was it. What are the equivalent symptoms in the locomotor system? Well, the first one is going to be pain. Because inevitably there is what we call involvement of now the joints. And pain is the whole characteristic, actually, the main characteristic of diseases of the locomotor system. And then coupled with pain, you often get this joint becomes stiff. And the patient will tell you that. The joint is stiff. The next thing they will complain of to you may be that that they are no longer able to use the joint. In other words, saying, my joint, I'm now weak in my hands. And in addition, and perhaps before I should have mentioned weakness, the patient may tell you themselves that the joint is swollen or deformed. So to recap then, pain, stiffness, joint swelling, and then finally, the consequence of that being there, either a short time or a long time, is the patient has what we call a disability. And if it's permanent, it can be a weakness, or as we're going to learn later on, the problems that arise as a result of arthritis. Let's talk a little bit about pain. What is specific about pain in the locomotor system? Well, number one will be, you are familiar with the 9 characteristics of pain, and all you have to do is apply that. It's sight, in other words, where is it? With SS goes severity, you're interested in. In this case, it'll be a joint. And the severity the patient will tell you. The time course I keep emphasizing for all pains. Its onset, its duration, and its progress. Is it getting better, getting worse? And what is it like now? That is the time frame. And then you're into what we call the modifying factors. Factors that make it worse, make it better, or associated with it, and have they ever had it before? Now, with joint disease, that is very particular. There are some characteristics in joint disease that may make it more specific. One is this kind of diurnal variation. It may vary over 24 hours. And for example, osteoarthritis is worse when you move on it, whereas inflammatory arthritis can be worse even at rest, particularly at night. So there are characteristics in arthritis. Obviously, the type of pain. Now it's going to be the patient will say it's paining, it's sharp or dull, depending on how acute the arthritis is. Remember, gout is one of the most painful conditions you can have. And osteoarthritis, when it's severe, the pain can be crippling, as in rheumatoid, same, and of course, and so on. So I'm just teaching you to elaborate on the pain. There may not be any other symptoms besides pain that help you to localize that the pain is coming from a joint. Moving on then from pain, you have swelling, and so what will be the characteristics about swelling? Well, swelling is just what it is. The patient will say, I have swelling in one area, and will describe whether it is a tender or a non-tender swelling, or is it, again, painful, non-painful, and the characteristics that go with it. Stiffness is very particular insofar as that the stiffness often is present on waking in the morning and then disappears as the day goes on. That is very characteristic of arthritis. The patient gets stiffened up in the morning, and then it takes them an hour or two to get going, and then they feel they're okay. And that is characteristic not just of what we call the rheumatoid group, the inflammatory ones, but you also get it with degenerative arthritis, worse sometimes in the morning. But again, exercise and movement may make it worse, which is the characteristic of arthritis. In other words, it's the movement that makes it worse. So I've mentioned to you pain, aggravated by movement, in this case, swelling, localized to the joints, stiffness, characteristically diurnal, worse in the mornings, and finally you're going to have weakness and disability. Now, disability is what arises as a result of the inability to do something. And of course, don't forget, as creatures, we are locomotor. We spend our time moving. And you can imagine then, if you have disease in your joints, you are now going to be disabled. Coupled with the cause of that may sometimes be actually weakness around the joints. In other words, if your joint is disabled for a long period, the muscles will atrophy. We'll come across this later as a physical sign called wasting around the deformed joints. That summarizes the main presenting complaints in arthritis. Now we move on to the past history. Now, what's relevant about the past history? Well, obviously, if there's a past history of arthritis, or anything that would cause arthritis. What would cause arthritis? Well, a road traffic accident, notoriously, where you actually have trauma to your joints or to your hip or your neck, and then sometime later you present with pain in the joint. And of course, I've mentioned already, if there is a past history of arthritis, which is characteristic of the inflammatory arthritis, in other words, the disease that may have been there before. Illnesses. With all past history, I emphasize that you need to document what we call the illness, whether it is active or inactive. In other words, is it ongoing? Hospitalizations and operations. And then specifically for rheumatological conditions, the question of inflammatory arthritis in the past, and in particular trauma. Moving on to the family history. Well, family history is interesting insofar as that there is an overlap between the arthritis. For example, connective tissue diseases are more common in families, like rheumatoid, lupus, slightly increased, and believe it or not, degenerative arthritis is more common, not in a dominant way, but in a way that is more common than it would be in the normal population. Gout, for example, runs in families. And that is xanthine oxidase inhibition, and maybe a hereditary deficiency of the enzyme, or whatever, or the deficiency, or an overexpression of it, and producing uric acid. So we do look for ankylosing spondylitis runs in families. HLA-27, I think, is the HLA phenotype for that. So these are examples of arthritis that run in families. So family history is important. And the way you would ask that is there any first-degree family history first-degree family member affected? That would mean a child, or a brother or sister, or a parent. And if they were there, then you would plot out the family tree, the age and how long they had it for. That would be of importance. Social history. Social history is more important from the point of view of the effects of the arthritis on the patient. And they can be huge, varying from unable to work, unable to do the activities of daily living, like self-caring. That means feeding, toileting, and dressing in the most severe cases. So you have a wide spectrum of disability which shows up in the social history. Obviously, alcohol is a precipitant for gout. Smoking increases the risk of some of the non-communicable diseases which may impede on your disability if you have an arthritis. So we do emphasize the usual points about social history. Their drug hit, their intake of smoking, and of course alcohol, and their occupation, and its consequences. Now moving on to drug history, there are some drugs that are a risk factor for arthritis, for example, the diuretics. The drug history follows the usual pattern for drug history. You have to document the drugs they're on, the dose they're on, and their duration, and any side effects, and specifically any allergies. Systems review tends not to be that helpful beyond the symptoms that I've mentioned. And already now we're moving on to what's called the phase of examination, and that's the next part of this tutorial. Thank you. Okay, so we're going to proceed with the second part of the tutorial this morning on the locomotor system. And we've done symptoms, and now we're going to do examination. And Daniel is a final year medical student here at KCMC, and he's very kindly volunteered to act as the guinea pig for this part of the examination, this part of the tutorial. I just want to remind you of some principles that apply right across all rheumatology. The first one is the joint. And all you have to think of, what's in a joint? Well, you've got bone in the middle. Next to bone, you've got what? Synovium. Next to synovium, you've got fluid. And then above synovium, you've got ligaments, tendons, nerves, and muscles. Now you can imagine there are something like 7 potential sites for pathology. That's the problem with rheumatology and with what we call orthopedics. It involves multiple, what we call tissues at different levels, and they all can be involved to one degree or another. Take, for example, a joint where the synovium is enlarged versus a joint where there's now an effusion in the joint. Two pathologies may occur together or maybe on their own. So that brings me on to the second part, the second principle of rheumatology, which is the underlying abnormality is mainly inflammation. Now, if you go back to your 4 principles of inflammation that you learned in your basic sciences, you get calor, dolor, rubor, and loss of function, isn't it? You get heat, swelling, redness, and loss of function. These are the cardinal features of all arthritis, if you think about them. There is going to be swelling, there's going to be heat, there's going to be loss of function, and pain, of course. And the obvious consequence of the loss of function will be disabilities. The patient will not be able to do something that they should do, and that may often be the presenting complaint. Doctor, I can't use my hands for typing, or I'm not able to write, or I'm not able to walk. And of course, as a consequence then of the arthritis, there will be deformity. And sometimes you can actually see it. And that's what the doctor often does. On inspection, you see the deformity in front of you, and you say that this patient has arthritis. So moving on then to going over them in principles, we remind ourselves, we do inspection, we do palpation, and then we do movement. So what sort of things are you going to look for on inspection? Well, the first one is swelling. The second one will be what I call deformity around the joint. There's often a characteristic deformity around the joint. And the other one will be muscle wasting. Now, you can imagine that the deformity and wasting are usually present when the disease is chronic. So in acute stage, you may just see swelling. The swelling will overlie the joints. And that, of course, will characterize the disease. You have a right and a left side, and you need to look at both and compare both. The deformity can be characteristic. For example, in rheumatoid arthritis, you get ulnar deviation. In arthritis in the elbow, you may have a flexion deformity, unable to extend it. Or, for example, in the hip joint, you may have what's called a valgus deformity with the feet turned out. So all along the examination, you are characterizing deformity. This is on inspection. Now moving on to palpation. This is quite important because you're going to feel what we call the inflammation in the joint, and the best way to do that is to use the back of your hand, not what we call it's actually the back of the fingers we use, and we slide it over the joint and we compare it to a non-joint area, and you go from cold to hot, go from normal to abnormal. That's the best way to do it. So you're also going to palpate the joint, feel it, and the palpation will reveal some aspect of what's going on in that joint. For example, if there's thickening, this is when you become suspicious of an effusion. You feel swelling, usually in the what we call the pouches around the joint, characteristic in the knee joint. Don't forget that when it comes to palpation, you have movement, and the inflammation will probably limit the range of movement, both actively and passively. Now, it's at this situation that we tend to do more passive movement than active movement. Active is what the patient does, passive is what you do. And in arthritis, we tend to move the joint very, very gingerly, very gently, looking at the patient's face with your hand over the joint, because you're going to feel for something. That's movement, and I'll come on to that in a minute. So I've emphasized that the patient has to be relaxed, to make sure you're not hurting them. It's going to be passive movement, and I mentioned already the limitations that may be there because of the joint swelling. Already there may be deformity, and there's something that you sometimes feel when there is inflammation. We call it crepitus, or it's a palpable sound where something is grating over something else. In other words, tissues are moving and they give rise to what's called a palpable sound, and you feel that as crepitus. There are different types of crepitus. One can arise from degenerative osteoarthritis, from bone on bone. Another can arise from synovium on synovium. But either way, you're aware with your palpating hand that there may be crepitus when you move the joint. And that principle is well established. We do examine the range of movement, and we'll talk about that when you come to individual joints. For example, the range of movement at my elbow is always 180 degrees. It's a straight line. The range of movement at my neck will be at least 75 degrees, what we call lateral rotation. And again, another 75 degrees on neck flexion. So when we move the joint passively, we check for the range of movements and see is that restricted. So in principle then, I've gone over the main points on examination. The first one is to determine are the joints involvement or not, and then which joints. Then you note on palpation for tenderness and for swelling. Then you determine the range of movements passively. You look for any muscle wasting. Don't ignore that. And finally, I know as a physician, and don't forget, there will be nobody above you where you're working. You will be the main physician. There may be involvement of other things around the joint. The muscle can be involved directly, or even the nerves, as we sometimes see in a median nerve involvement in arthritis around the wrist, or an ulnar nerve involvement here. So you may have to extend your examination to involve a nerve. So they are the main points that I want to emphasize at this stage before I go on to demonstrate the examination of individual joints. The examination of the individual joints will start with gait, move on to spine, and then go on to individual joints. So I'll start with gait. What am I looking for? Well, I'm just looking to see, is the gait normal? I'm looking at the shape of his spine. I'm looking at his legs to see that, making sure he doesn't have any limping. And I'm looking to see, does he have normal, what we call gait swing. So, the sort of things that cause an abnormality in gait in the locomotor system would be, say, arthritis of the hip, or maybe an inflammation in the hip, when the patient doesn't allow the leg to spend much time on the ground, and then you see a compensating movement going on, or maybe a short leg, like that. And in other words, there are many deformities or abnormalities of gait arising from diseases of the locomotor system, particularly arthritis of the hips and the spine. And that's the point I want to emphasize today. And you will not find them unless you look for them. In other words, you have to make the patient walk in front of you and inspect. The spine has three components which you know: cervical, thoracic, and lumbar. And what you have to do is to look to inspect. They all have to be inspected in different positions. For example, the neck, you have to inspect from the side, because I'm looking for the normal lordosis of this cervical spine, and this way I see it's normal. I have to look at it from the front and see, is there any abnormality? Is there spine, is the neck moving to one side or the other? And I'm interested in his posture. The next thing I can do is, remember the principles: you inspect, you palpate, and you move. You have to feel it. For example, if a patient has inflammation in a bone, then just by palpation you pick it up, because the patient won't allow you to touch that part of the spine. And then we come to movements. Now, movements of the neck are very important clinically, and you will not be taught this again, I think. The way to do it is to ask the patient to move actively before you do it passively. So Danielle, can you do the following? Can you put your chin down on your chest, right down on your chest, right down, that's it. So he gets down to about what we call, he's able to move about a 75-degree arc, that's normal. Now go back to the midline. Now can you extend your neck backwards? You see, that's almost as good from that position. Again, probably around 65, 70 degrees, okay? Then do lateral flexion. Put your right side of your head on your right shoulder. And again, we're getting over 45 degrees, but in this case it's around 45 degrees, okay? Again, tilt to the left, about 45 degrees, which is normal. And finally, turn your head to the left, right out, to the left. Now you see almost 90 degrees, 80 degrees of movement. I call it the swivel movement. And you see how normal that is. And then turn to the right. Now, if I were to check that passively, all I would do is do exactly the same thing. Just gently allow me to bend chin in your chest, bend your head backwards, put your head on your left shoulder. I'm just feeling his neck for crepitus, head on the right shoulder. Now rotate your head to the left and to the right. And that's a normal neck. That's important for you to be able to do, because limitations of that movement will be the first sign of disease in the cervical spine. And the commonest disease is cervical spondylosis. And in particular, that's a disease of aging. Please remember, you have to always be gentle with the movements of the spine. It's a gentle examination. Now moving on to the thoracic spine. Then, again, you inspect the thoracic spine from a number of positions, okay, from the front. And I don't see any obvious deformity in the chest. I look at it from behind, and now I'm looking for a kyphosis or a scoliosis, because that's where we see it most often. In other words, either a prominence in the midline or sideways. And of course, I look at it from the side and see it's the normal dorsal kyphosis in that position. The thoracic spine is important to palpate when you suspect an abnormality. For example, in Pott's disease, you may find spinal tenderness. That may be the only sign, and a deformity. If you do feel an area of tenderness, you have to define it, localize where it is. You do that by tapping. You can use your finger like this, listen. Just tap the spines. Or you can use your patella hammer and tap the spines. Either way, it's important to localize where the tenderness is arising. It's also important to show you that the movement of the thoracic spine takes place at the area of the lumbosacral spine. It's a rotatory movement, and it's a flexion and extension movement. And it's tested in the seated position, not the standing position. So, Danielle, what I'd like you to do now is lean forward, come forward on the chair a bit. And what I'd like you to do is to turn your whole body to the left, keeping your knees straight. Your knees straight. Now you see the movement there. The thoracic spine is moving on the lumbosacral spine a huge amount. It's almost 90 degrees. And check the other side. Again, keep your knees straight, please. Keep your knees straight. Then now do the movement. You see exactly the same movement there. The rotation is at the lumbosacral spine. Now do flexion forward in this position. And that could be tested in the standing position. I'm just doing it for convenience, in the seated position, and so on. Okay. So, coming to the lumbar spine, and the lumbar spine is the site of a huge amount of pathology. Then again, I'm looking for loss of the normal lordosis. Can you stand up, please? And if you look there, there is a normal lordosis. If you turn around and face the class, here you see the normal lumbar lordosis. It's the loss of that is important, the loss of it. That is the first implication that you have disease of the lumbosacral spine. And then, if we test him for movements, and I'll demonstrate the following movements, we demonstrate those in the standing position as follows. So Danielle, I'm going to get you to, with your knees straight, touch your toes. Watch this. You see it's perfect. This is a normal movement now occurring at the end of the lumbosacral spine, normal. We call that flexion. Then do extension. Now you see the extent of extension. It's almost approaching 45 degrees. And then you do lateral flexion this way. Again, and lateral flexion to the other side. Again over about 45 degrees. It's when those movements are impaired or lost or cause pain, they localize. There are two specific examinations I just need to remind the students about. One is the straight leg raising test, and the other is the femoral nerve stretch test. The straight leg raising test is a test usually for disease compressing the sciatic nerve or a branch of it. The way we test for it is ever so simple. You lie the patient flat, you extend the legs, you take the heel of the leg that you're testing and you flex the hip, all the time asking the patient, is it painful? The very minute the patient says it is painful, that is a positive, what we call straight leg raising test or sciatic stretch test. Usually you and I can do this up to 90 degrees without any problems. If it's positive, it'll become positive very quickly, often 20 degrees, sometimes even 10, sometimes at 60 degrees. In a similar way, we stretch the femoral nerve by turning the patient over in a supine position, keeping him completely straight with the legs extended. And now what you do is you flex the knee, because that's stretching the femoral nerve. And if that doesn't cause pain, you can actually slightly extend the hip. Now, I'm not going to demonstrate this on Danielle today. Maybe if we have a patient on the ward with it, we'll demonstrate it to you. But I'm just emphasizing that you need to know it. What confounds the students and the straight leg raising test is the sign for meningitis. Okay? Does anybody know the name of the sign? Which one? Not Brzezinski. Kernig sign. You have three signs of meningitis. You have neck stiffness, you've got Brzezinski sign, and you've got Kernig sign. Kernig sign is exactly the same. When you flex the knee to 90 degrees, you try to straighten it, you stretch the meninges, and the meninges are inflamed and the patient complains of pain. So please remember to differentiate those two tests. Thank you. So now we're moving on to examination of the joints in the limbs. And usually there may be either multiple joints involved or one joint. The classic example would be rheumatoid with multiple and one joint with gout. The disease can be, it's mainly inflammatory, but maybe non-inflammatory, for example, trauma. And so you review the symptoms that I mentioned in my earlier presentation about pain, stiffness, and swelling, and then weakness. Something that does come up for discussion is sometimes pain from joints is referred. For example, the shoulder joint may be referred to the arm, the elbow may be referred to the forearm, and hip may be referred to the knee. So you have to watch for that. And of course you've done your history and you're still interested, was there any specific risk factor in this patient for his disease? Moving on then to the specific joints in the upper limbs. The main ones are at the wrist here, and I'll put on my glasses. This is the wrist joint, the metacarpophalangeal joint, and the interphalangeal joint. And the interphalangeal joints are both proximal and distal. So what am I looking for? Well, at the hand, of course, I'm looking for swelling on the dorsal aspect usually, the dorsal aspect, loss of contour of the, what we call the wrist. That's the first sign. And the swelling, as I said before, I've talked about that. In addition then, we said you look for deformity and particularly position. And characteristically with the wrist joint disease, we look for ulnar deviation. You may look for wasting in the small hand muscles. And you turn the hand over from the dorsal side to the ventral side. And in particular, you're looking at the thenar, the hypothenar, and the small hand muscles. Going down to the metacarpophalangeal joint, you're looking for any deformity and swelling, and in particular of the second and third. That's where we often see it with the rheumatoid. And in the interphalangeal joint, and that may manifest itself as spindling. They call it just swelling and deformities of the joint. And you also look for wasting in the forearm. Coming up to the elbow, well, you're looking for any deformity in position, because there already may be a flexion deformity. The elbow, you may not see much swelling, because the synovium there is deep, and it's an area where you tend to see the deformity before the swelling. But on palpation, it should be apparent to you, because you pick up the local heat, and of course, and look for any what we call obvious deformity. Checking for movement, you're interested in flexion again and extension, and now you're interested in supination and pronation. Don't forget that the head of the radius is a synovial joint, and you can feel for crepitus all the time with your palpating hand and your non-moving hand. Moving on to the shoulder. The shoulder is not easy. Again, because it's covered with the deltoid muscle, and swelling may not be apparent. Now, the shoulder is important to inspect. You inspect it from the front, and that's where you may see prominence of the acromion process. You may see wasting of the deltoid, or a deformity. You look from behind and from the side. Then you palpate. And now you're interested, is there any local heat, any tenderness, and any abnormality on movement, all the time looking at the patient's face. And then you will often go on and ask the patient to do active movements in the shoulder before you do passive movements. One of the reasons is that the patient can demonstrate it better than you can. So can you elevate your hands, your arms over your head? Good. Now put them back by your sides. So he's able to now take them out like a butterfly, abduct, he's able to elevate, put them back by your sides, hold them like that, that's flexion. And then sit forward a bit and do extension for me behind. Okay, and then hold them up like this, turn them in, internal rotation, and turn them out. External rotation. And finally, you can do that for me. That's circumduction. It's a ball and socket joint, so you've got all potential range of movements. In summary, I've done abduction, I've done flexion, extension, and I've done internal, external rotation, and circumduction. And any limitation in those movements points to a disease in and around the shoulder joint. So moving on then to the lower limbs. The joints involved in the lower limbs are the same. You have your ankle joint is the main foot one, but you also have your metatarsophalangeal joints there, and your foot bones. You also have your knee joint and you have your hip joint. Now the difference about these joints is these are all weight-bearing joints, and they're hugely involved in degenerative arthritis. And of course, their examination individually is probably best demonstrated either with the patient lying and of course mobile in certain situations. Starting with the hip joint, well, it's wise to remember that pain is usually the presenting complaint that alerts the patient and alerts the doctor to disease there. Just a word of warning, with the hip joint you have to inspect not just lying but also standing and on walking. Just like I did with gait, because it's the main weight-bearing joint and that's where we see the pathology. When the patient is lying, what sort of indications are there that there is disease in the hip joint? Well, every medical student is familiar with the shortened leg and with the abducted foot, typical of a fracture of the neck of femur. And of course, degenerative arthritis can cause a similar type of deformity when it is long-standing and the acetabulum is destroyed. So we look for that. You obviously palpate the joint on the principle that you inspect and you palpate. And the hip joint is like the shoulder joint, it's the ball and socket joint. So you get the patient to do as much as they can first with hip flexion, hip extension. Hip flexion is 90 degrees, hip flexion is usually 30 degrees. Then they can abduct, they can adduct, and they can circumrotate. You get them to do that actively and then you do it passively. And by then you should have information about the joint. Obviously, if there's wasting in muscle, and you would comment on that. Moving on to the knee joint. Again, we usually examine the knee joint in the lying position, but we inspect on walking. And again, you're going to check for any deformity in the knee joint. That's what you're after. In particular, is there any swelling, any change in skin color, and is there any obvious deformity in the limb, distal to it? So you do your inspection. Palpation is you put a palpating hand on the knee, you put the joint through its full range of movement passively, and you look at the patient's face. The knee is where we feel crepitus, and the knee is where we pick up effusions. If there's a suspected effusion in the knee joint, you should check for the presence or absence of a patellar tap. Now, I'll demonstrate that sign to you when we have a patient on the ward with it. I can't do it now in this cold situation. It's wise to remember that the knee joint is probably one of the joints where stability is most important, and you see diseases of ligaments all the time, both cruciate and medial and lateral. And you can check for cruciate ligament stability by special examination technique, and for medial and lateral stability in the same way. Again, these are best demonstrated with patients in the bed with active with disease, and I won't go through that now. Common abnormalities around the knee joint are a flexion deformity. You can get the knee is just fixed in that position. You can get a cyst called a Baker's cyst, which can cause confusion at the back, protruding through the posterior ligaments, part of the synovium, mimicking disease. And of course you get wasting in the quadriceps. Moving down to the ankle joint. Characteristically, the ankle joint is involved after trauma and rheumatoid arthritis and in severe degenerative arthritis where there's an abnormality. So again, the principle follows inspection, palpation. The movement at the ankle joint is rather limited. You've got both flexion and extension. Now, the range of movement is severely limited. And of interest is there is what we call inversion and eversion, but that does not take place at the ankle joint. It takes place at the taloid joints. And of course, so movement then is tested actively and passively, and then you describe any other abnormality that strikes you. And then finally, with the small joints of the foot, you need to examine them by inspection, and again by palpation. And a little word of warning here from an old physician. Tenderness in the metatarsal heads is the single most important test for rheumatoid arthritis clinically. It's called lateral or side-to-side compression, and the patient will wince or jump when you do it, and it implies that there is synovial involvement in all the metatarsal joints. In other words, side-to-side compression of the metatarsal heads is a very useful sign in clinical medicine of inflammation of the synovium, and that is characteristic of rheumatoid arthritis. Now, that is a rough overview of examination of the locomotor system, and I've concluded the tutorial for today. Thank you.